Good evening, ladies and gentlemen. My name is Osama Barakat. I'm a consultant endocrinologist from Abu Dhabi. It's my pleasure to talk to you tonight, and the subject of my topic will be Vascepa, icosapent ethyl, a practice-changing medication for persistent cardiovascular risk reduction. We all know that cardiovascular disease remain the leading cause of death globally, and the number of deaths due to heart disease is no longer declining, as you can see from the evidence. Despite a very systematic and strict reduction of LDL cholesterol, which is the main cause of cardiovascular disease, you can see in the major trials that patients who have been fully treated with a statin and achieved a good LDL cholesterol reduction remained at high risk of residual cardiovascular disease. And most recent publication from Professor Bahat, you can see even with the statin therapy alongside non-statin novel therapy, so combination lipid-lowering treatment with PCSK9 inhibitor and ezetimibe alongside statin, patients who have achieved a very good LDL reduction in those trials remained at significant residual risk for cardiovascular disease. So there must be something behind this. And for a long time, we've known, but we've gently ignored the risk of high triglyceride and high triglyceride-rich lipoprotein. So we know high triglyceride is a marker of increased cardiovascular risk, which is residual after LDL control with statin. And we see this quite a lot in people with vesicular obesity, type 2 diabetes, chronic kidney disease, and metabolic dysfunction. As you can see from those studies, the Miracle clinical trial and the Framingham offspring study, that people who have high triglyceride do have a large residual risk and at increased risk of cardiovascular disease and other microvascular complication. New real-world data, the Kaiser report, shows again that patients with increased triglyceride remain at risk of non-fatal MI, non-fatal stroke, unstable angina, and all-cause mortality. It's very important to understand how icosapent ethyl, pure APA, work. Now, we know that triglyceride, rich lipoprotein, does cause damage by infiltrating the endothelial barrier, and then it's taken into the intima, then taken up by the macrophages to start a foam cell formation, which eventually lead to plaque formation. In addition, we know that high triglyceride or triglyceride-rich lipoprotein do tend to increase thrombotic tendency by working as a pro-inflammatory particles and increases platelet aggregation. So APA is believed to block free radical progression through the phospholipid monolayer, preventing lipid oxidation and deleterious changes in lipid structure organization. In addition, we know in early phase that icosapent ethyl increases endothelial function and reduces oxidation and reduces LDL remnants. Then later on, it reduces inflammation, which eventually lead to reduction in plaque progression, stabilization of plaque and reducing plaque rupture, reducing platelet aggregation, and thrombus formation. Those results were purely seen in APA only. So the addition of DHA to APA tend to lower the benefit seen from APA. So those properties are purely limited to APA or purified APA. If we look at the clinical aspect of icosapent ethyl, we start with the major trial, the REDUCE trial, which is the reduction of cardiovascular events with icosapent ethyl intervention trial, which took a group of secondary prevention and primary prevention patients. So they took patients above the age of 45 with established cardiovascular disease. Those were the secondary prevention, or patients above the age of 50 with diabetes alongside one additional risk factor, and those were the primary prevention cohort. The fasting baseline triglyceride for those patients were between 150 and 499 milligram per deciliter. The patient had a very good LDL between 40 to 100 milligram per deciliter, and this was achieved with a stable statin therapy plus ezetimibe for at least 4 weeks prior to qualifying measurements for randomization. 8,179 adult patients with well-controlled LDL cholesterol and elevated triglyceride, where 71% of them were secondary prevention patients and 29% of them were primary prevention, who randomized either to statin plus icosapent ethyl 4 grams per day, where the other group were on statin plus placebo. A primary endpoint and secondary endpoint were set. The primary endpoint concluded of 5-point MACE, which is non-fatal MI, non-fatal stroke, cardiovascular death, coronary revascularization, unstable angina needing hospitalization, and the secondary endpoints were non-fatal MI, non-fatal stroke, and cardiovascular death. And here we can see that the primary endpoint was met with a 25% relative risk reduction and number needed to treat 21 and hazard ratio of 0.75 in favor of the statin plus icosapent ethyl group. Similarly, a 26% reduction with a number needed to treat of 28 and hazard ratio of 0.74 in the secondary endpoint, again in favor of icosapent ethyl and statin. If you want to break all the component of the composite, you can see a 26% reduction in non-fatal MI, 31% reduction in fatal and non-fatal myocardial infarction, 28% reduction in fatal and non-fatal stroke, and 20% reduction in cardiovascular death. And if you look at the patient with a prior cardiovascular event or at risk of further cardiovascular event, you see those patients had reduction in total event over time. Very interestingly, that the outcome was not related to the baseline level of triglyceride or on treatment triglyceride level, which gives an advantage probably to the purified APA properties and mechanism of action. So regardless of the baseline triglyceride or the level of triglyceride while on treatment, there was no heterogeneity in terms of cardiovascular benefit, as you can see in this slide. If you look at the total event, you can see there was 159 cardiovascular events prevented per 1,000 patients treated. So approximately 1 cardiovascular event was prevented for every 6 patients treated with icosapent ethyl over a period of 5 years, which is quite significant. In terms of adverse effect, you can see quite similar adverse effect or adverse event between the icosapent ethyl and placebo, with probably more constipation in terms of GI side effect. Now, atrial fibrillation or atrial flutter require hospitalization occurred in 3.1% in icosapent ethyl and 2.1% in placebo. Atrial fibrillation was a safety endpoint since not requiring hospitalization. But you can see there was no statistical significance for the atrial fibrillation occurrence. If you look at bleeding from gastrointestinal or central nervous system or other bleeding, you see numerically higher adverse event relating to bleeding in the icosapent ethyl arm, but overall rate were very low, and there was no fatal bleeding in either groups. Now, subsequent analysis from the reduced APA, that's really to tell us that the reduction in event was related to the level of APA while on treatment. So compared with the placebo, icosapent ethyl 4 grams per day significantly reduced first and total cardiovascular event by 25% and 30% respectively. These benefits were beyond what can be explained by the degree of triglyceride or other biomarker changes, as we've shown you before. On-treatment APA level via icosapent ethyl correlates strongly with the primary endpoint. The key secondary endpoint, cardiovascular death, MI, stroke, coronary revascularization, unstable angina, sudden cardiac death, cardiac arrest, new heart failure, and all-cause mortality. This data provide a mechanistic underpinning for the large risk reduction seen in multiple endpoints with icosapent ethyl in the reduced trial. A large number of our patients that we see in practice are diabetic patients or patients with metabolic dysfunction, whom you see quite a lot of not very high LDL, but the lowish HDL and raised triglyceride. Those are the patients, like obese patients, who have probably the largest amount of triglyceride-rich lipoprotein. And as you can see, the standard of care was implemented in all those diabetic patients, and they were quite similar between the icosapent ethyl and the placebo group in terms of number of medication to treat diabetes. And if you look at the first and subsequent event, the full data set for the diabetes subgroup of 4,787 patients, there you can see there was a reduction in the first, second, and third event in favor of the icosapent ethyl group in diabetic patient versus placebo, with a 24% reduction in total event. And if you look at time to first and total primary endpoint by cardiovascular risk category in diabetes, so if you look at the first one, patients without established cardiovascular disease, but with diabetes and other risk factors. And here you can see reduction was in favor of icosapent ethyl for those patients, with a 22% for the total event and 14.3% for the first event. Patient with established cardiovascular disease and diabetes, and those are the highest risk group, had a 58% reduction in total events and 30.8% reduction in first event. And if you look at patients with established cardiovascular disease but no diabetes, here you can see a 31.5% reduction in total event and 21.2% reduction in first event. So patient who got most of the patient benefit are patients with diabetes and established cardiovascular disease. And needless to say that those are the patients who have seen benefit even in LDL reduction trials. So in conclusion, Compared with placebo, icosapent ethyl 4 grams per day significantly reduced both first and total primary endpoints event in patients with diabetes at baseline by 23 and 24% respectively. For the key secondary endpoint of hard MACE, reductions for the first and total events were 30 and 29% respectively. Reductions were consistent and robust across the pre-specified hierarchy of endpoints among patients with diabetes with or without cardiovascular disease, as well as those with established cardiovascular disease and no diabetes at baseline. These data highlight the substantial impact of icosapent ethyl on the underlying atherothrombotic burden in the at-risk reduced population, both in those with, but also in those without diabetes at baseline. Another sub-analysis from the REDUCE-IT is the REDUCE-IT stroke. And here we can see that icosapent ethyl reduces the first and total ischemic strokes with a significant p-value of 0.003 and relative risk reduction of 0.64 in favor of icosapent ethyl in terms of reduction in ischemic stroke. Now, another important trial, which is the REDUCE-IT prior MI, and this is the reduction in ischemic event, including cardiovascular mortality with icosapent ethyl in patients with a prior myocardial infarction, and that's called the REDUCE-IT prior MI. And what we can see here, first and total primary and key secondary endpoint with a patient with a prior MI were reduced in patient on icosapent ethyl. We can see a hazard ratio of 0.74 for the primary composite endpoint and a hazard ratio of 0.71 for the secondary composite endpoint. Now, if you look at the REDUCE-IT subgroup analysis, and you can see the reduction across patients with prior MI, reduction in revasc, patient with CABG, patient previous PCI, renal disease, diabetes, unstable angina, patient who are smoker, people who had non-STEMI, prior peripheral arterial disease, patient with a stroke. So throughout the macrovascular bed complication, there was no heterogeneity, and benefit was there in all those subgroup analyses with a relative risk reduction for the primary composite endpoint of around 25%. So a significant reduction throughout. The last trial we will discuss tonight is the EVAPORATE final. That's more of a slightly different trial looking at the effect of icosapent ethyl on progression of the coronary atherosclerosis in patients with elevated triglyceride on statin therapy. And this is really effect on APA on improving coronary atherosclerosis in people with high triglyceride taking statin therapy is randomized, double-blinded, placebo-controlled. Patient between the age of 30 to 85 with a triglyceride between 135 to 499 milligram per deciliter, and LDL cholesterol between 40 to 115 milligram per deciliter on statin, one or more angiographic stenosis with more than 20% narrowing by CT angiogram. So this is more of a radiological trial. No history of myocardial infarction, stroke, CABG, or life-threatening arrhythmia in the prior 6 months. And 80 patients randomized into 4 grams of APA or placebo for a period of 18 months. The primary endpoint was a progression rate of low attenuation plaque. The secondary endpoint was plaque morphology and composition, so non-calcified, total, fibrous, fibrofatty, calcified, and markers of inflammation like LP, PLA2, LDL cholesterol, and HDL cholesterol. And if you look at the observation, was change in plaque quantity based on treatment group. And what you can see, patient in blue, who the icosapent ethyl, had most of the benefit in terms of low attenuation plaque and reduction in total null calcified and total plaques in general. So the change in plaque quantity was in favor for patient on icosapent ethyl. Remember, this observation was done by CT angiogram. And if you look at time for coronary revascularization, very early benefit demonstrated with consistent statistical significance obtained by 18 months with a hazard ratio of 0.66, relative risk reduction 34%, absolute risk reduction 4.1%, with a number needed to treat of 24. A significant reduction for time for coronary revascularization for patient on icosapent ethyl. In conclusion, compared with the placebo, icosapent ethyl 4 grams per day significantly reduced multiple plaque components, including vulnerable low attenuation plaque. Very early effect, 9 months, with a sustained and increasing significance by 18 months. And to the best of our knowledge, this is the first elegant marriage of clinical trial results, reduce it, and imaging trial, evaporate, demonstrating consistent benefit of icosapent ethyl on both outcomes and plaque reduction. These data highlight the early and substantial impact of icosapent ethyl on the atherothrombotic burden in the at-risk population. Now, finally, when we talk about reduction of high triglyceride, if we look at the international guidelines, starting with the ACE guidelines 2022, clearly says if patient has a triglyceride above 500 milligram per deciliter, then you use fibrate, then you upgrade your treatment by using omega-3 fatty acids, but clearly demonstrate and highlight that if triglyceride is 135 to 499 in patients who are high risk of ASVD, then you must add icosapent ethyl 4 grams per day to gain cardiovascular reduction benefit. If you look at the American Heart Association, American Stroke Association guidelines 2021, it clearly says treatment with icosapent ethyl IPE 2 grams twice a day is reasonable to reduce the risk of recurrent stroke in patients clearly with a ischemic stroke or TIA with a fasting triglyceride between 135 to 499 per gram per deciliter and LDL cholesterol between 41 to 100 milligram per deciliter on moderate or high intensity statin therapy. And if you look at the European Society guidelines in 2021, it says clearly in high risk or above patient with triglyceride more than 135 milligram per deciliter or 1.5 millimole, despite statin treatment and lifestyle measurement, icosapent ethyl 4 grams per day may be considered in a combination with a statin. With this, I would like to thank you very much, and I'm more than happy to take any questions. Thank you.